Hello, welcome to the Radiology Economics and Policy Learning Electronic Toolkit, Replete. I'm Rich Duzak from Emory University, and this module is the second part of the series on utilization entitled Optimizing Appropriateness. This module is targeted to Level 5 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Milestones levels differ for the various ACGME-approved radiology training programs, and so if you are in a program other than diagnostic radiology, please reference the Replete resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows: to describe policy initiatives by Medicare, private payers, health systems, and professional societies initiated to optimize the appropriate use of medical imaging, to outline flaws in historic approaches to utilization management in radiology, and to effectively implement real-time decision support tools into clinical practice workflow in a manner that ensures radiologist relevancy and optimizes the value of medical imaging. Here are two recent review articles for those who would like to learn more about the topics in this module. In the last session on utilization, we reviewed the growth of healthcare spending as a percentage of gross domestic product. You now know that we're on a trajectory that, unchanged, by 2025 means that approximately 1 out of every $4 spent in this country will go to healthcare. That's clearly unsustainable, since those are dollars that otherwise would go for food, housing, education, infrastructure, and a variety of other important products and services. You also know that medical imaging has been in the crosshairs as policymakers have sought to reduce spending on healthcare services. That's because from 2000 through approximately 2007, the annual rate of growth in medical imaging was, on a percentage basis, faster than any other sector of physician professional services. As a result, a variety of policy initiatives were implemented by Medicare and others. We have talked about some of these previously. The ones that you see here illustrated in this graphic from the American College of Radiology are highlighted in color, with red indicating changes unfavorable to radiologists and their hospitals, and green indicating the couple that have been favorable, along with the sizes of the circles, reflecting the relative magnitude of those changes. The bottom line here is there's a lot of red. Most of these policies were implemented in an uncoordinated frenzy to reduce spending. And that they did, but perhaps too well. Because since 2007, the relative annual growth in medical imaging spending didn't just slow, it actually reversed, as you see here with growth curves below the zero line in gray, while spending on non-imaging healthcare services, illustrated in yellow, continued to increase. And what we've seen as a result, here illustrated with Medicare Part B spending, is that spending on medical imaging each year has continued to fall during that entire time. Policymakers, you now know, have only 3 ways to cut spending on healthcare. They can cut costs through unit price reductions, or they can cut volumes through reduced utilization, or they can do both. And that they have. We've talked in a variety of modules in the past on ways that unit cost reductions have been implemented through the RBRVS process and subsequent Medicare physician fee schedule reductions, and through code bundling and code edits. In this module, we will focus on several initiatives in recent years designed to reduce utilization, and we'll talk about self-referral, radiology benefits management companies, and computerized physician order entry with embedded decision support. Let's step back for a minute first, though, and remind ourselves what's driving utilization. A lot of what's driving the utilization of medical imaging is the fact that it's so good. Perhaps in some ways the best thing since sliced bread, as you've learned about when we talked about this study by Fuchs and Sachs about what leading internists thought were the most important innovations in medicine during their time in clinical practice. Remember that I told you radiology eclipsed many other services, with MRI and CT first on this list, balloon angioplasty at number 3, mammography at number 5, and ultrasound at number 11. These are all good reasons for imaging to grow. But there are some not so good reasons as well. Here's another article surveying primary care physicians about the utilization of healthcare services. Overall, they thought their patients were getting too much care, and imaging was a part of that. And why did they think that's happening? They and specialists are utilizing healthcare services on their patients, and that includes ordering more imaging for a number of reasons. 40% thought it's because they don't have enough time to spend with their patients. 52% said they were doing it to play the games of clinical performance metrics. 62% said that it's because the specialists can use imaging to generate revenue. But importantly, 76% said it was because of malpractice concerns. In fact, 83% were concerned about being sued for failing to order an indicated study. And that last one is particularly important because there is good evidence and increasing evidence to show that defensive medicine, including ordering more testing, reduces a physician's likelihood of getting sued. That puts us as physicians between a rock and a hard place. Society wants us to reduce costs, but that same society, through its lawyers and its courts and its juries, has put us all in positions where we need to protect our own self-interests, preserving our reputations and our licenses and our jobs. Ultimately, these misaligned goals are going to have to get reconciled. But sadly, there doesn't seem to be much interest at the federal level in taking on tort reform. And just for clarity, tort reform will not fix all of healthcare spending woes, but it definitely has to be part of a coordinated plan. Because we can't fix our society's spending problem unless we're willing to tackle liability and the defensive medicine that results from it and drives at least some of that spending. In all fairness, though, those interests of self-preservation have impacted the behavior of many radiologists in financial ways, too. Some have focused perhaps too much on income preservation as policymakers have sought to reduce spending on imaging. Many of us are aware of studies that are ordered that shouldn't be. But in some private practices, radiologists have taken on the Nike imperative. Just do it, is what some say when asked to perform an injudicious test. Because saying no in our current system means not getting paid. We're saying just do it when faced with a request for an unnecessary study, at least in a fee-for-service world, means that you will get paid. This is where the incentives from broader policy initiatives will increasingly come into play. In the past, the value-based modifier, a measure of a physician's cost of caring for patients, impacted his or her take-home pay in only a negligible manner, and it didn't impact radiologists at all. But with MIPS now coming into play, as you now know from prior modules, costs will soon make up almost a third of most physicians' composite scores, as you see here in green over time. And those composite scores, you also know, will determine whether you get a bonus from CMS or a penalty, with a dollar differential that could be as much as 20%. When physicians start seeing this happen, I predict that many will start thinking twice when they invoke the Nike imperative in the setting of an unwarranted study. With all of that as background, let's now take a bit of a deep dive into 3 of the policy and business initiatives that have impacted radiology in recent years, all intended, at least ostensibly, in ensuring the more judicious use of medical imaging. We'll talk about restrictions on self-referral, the radiology benefits management service companies, and decision support software, each separately. First, self-referral. In an earlier module, highlighting some of the perverse incentives of the fee-for-service payment system, we discussed self-referral. The hallmark study that I cited to you was published by Dr. Bruce Hillman in the New England Journal of Medicine in 1990. Analyzing claims for over 65,000 episodes of outpatient care from a large private insurance claims database, he found that physicians who do not refer their patients to radiologists for medical imaging use imaging examinations more frequently than do physicians who refer their patients to radiologists. What does that mean? Physicians who refer patients to their own practices for imaging use that imaging at much higher rates. But that was published way back in 1990, and at that point CT and MRI were still in their infancies. And so most of that self-referral was in the form of radiography. But even in the era of cross-sectional imaging, Hillman's observations still ring true. Leveraging even bigger data sets over 25 years later, Dr. Scott Gazelle's team analyzed 526 million claims. That's over 500 million claims from a large national employer-based health plan from 1999 through 2003. And what did they found? They found that same specialty referring physicians tend to utilize imaging more frequently than do physicians who refer their patients to radiologists. Again, physicians who refer imaging to their own practices use imaging at much higher rates. Importantly, that referral rate disparity was not explained by case mix, patient age, or patient comorbidities. So, while there are a lot of reasons that physicians may self-refer medical imaging, financial incentives are clearly on that list. It's also important to recognize the magnitude of spending on medical imaging by physician specialty, that is, radiologists versus non-radiologists. Here's some work by our team from several years ago, looking at Medicare Part B spending. Of all Medicare physician fee schedule spending on medical imaging, 46% goes to radiologists and 54% goes to non-radiologists. That's right, you heard me. More dollars on imaging go to non-radiologists than to radiologists. Probably because many of them are billing both professional component and technical component, whereas most radiologists are doing much of their work in the hospital setting, billing only professional services with their hospitals billing technical services. Of the non-radiology specialties billing the most on medical imaging, cardiology, internal medicine, and orthopedic surgery were at the top of the list. It's important to note as well that there is a good bit of geographic variability in these ratios. But that said, total Medicare physician fee schedule payments for medical imaging to non-radiologists exceed those to radiologists in more than half of all U.S. states. I won't go into the details of the Stark Law again here. We've talked about it in a prior module. But in short, this was a good effort by former Congressman Pete Stark to minimize financially incentivized self-referral. But unfortunately, there's a loophole in the law, big enough to drive a truck through. And that's the in-office ancillary services exception. What this means is that a self-referred imaging service, or a laboratory service, or other so-called designated health service is not prohibited if it meets specific criteria. In short, these are two: that the services are personally furnished by the ordering physician or one of his or her partners, and secondly, furnished in the same office building or a centralized building that's used by the group practice for some of their clinical services. And so, while this permits very legitimate services to be performed, such as allowing cardiologists to perform EKGs in their offices when evaluating patients with chest pain, it has also created a huge healthcare, legal, and consultancy industry, crafting all sorts of creative arrangements that comply with the letter of the Stark Law, but not necessarily, at least in my opinion, its spirit. So, we see things like expansive private imaging centers with maybe an itty-bitty exam room on site, so the group can legitimately state that they provide some clinical services there. Unfortunately, there does not seem to be much political will in Congress to take on this issue. For as hard as radiologists will lobby for our interests and those of our patients, many of those other specialists are not surprisingly actively doing the same for their own. Let's shift gears now to the Radiology Benefits Management Companies, RBMs. The acronym is short for Radiology Benefits Management Company, and these are outsourced imaging utilization management entities that have historically provided services for private commercial payers, but are now increasingly servicing Medicaid and Medicare Advantage plans as well. Some of these are paid on a per-click basis, say $1 per member per month from the insurance company, but many are paid through risk-based contracts, meaning the more studies they deny, the more money they make. And so there is a considerable moral hazard in the business model of some that's not necessarily in the best interests of patients. You see listed here alphabetically the four big companies in this space: American Imaging Management, EviCore, which is the recent merger of Med Solutions and CareCore National, Health Help, and National Imaging Associates. This flowchart, which was provided to me generously by Dr. Mark Hyatt, the former Chief Medical Officer of Health Help, outlines the pre-authorization process that applies in some form or another at these various companies. First, it is important to note that these policies typically don't apply in the inpatient or emergency department setting or for radiography. Most of the time, it's just for elective advanced imaging, such as CT or MRI or PET. In short, a referring physician seeking to obtain an elective advanced imaging study on his or her patient has to jump through a number of hoops. Most of the time, there's a telephone call, or now, with some organizations, an online submission process that gets reviewed by a clinical service representative, usually not a licensed healthcare provider. If the study meets the right medical necessity rules on their computer screen, it gets approved. And if it doesn't, then the physician has the option to push his or her request up the chain to a nurse and then later a physician reviewer if he or she chooses to continue to appeal a denial. Here's some work by Dr. Dave Levin studying the system in place at Health Help. You can see that most dispositions for requests for imaging studies are addressed at the clinical service representative level, with fewer going on to nurses if ordering physicians don't get approval for what they want or think they want, and even fewer yet going on to subspecialty physicians for the same reasons. One thing to note is that the chances for approval at each level continue to be 2 out of 3 or better, but also that requests increasingly get withdrawn as they work their way up the chain. Perhaps that's because the ordering physician learns more about the test and its limitations and decides it really wasn't the best thing to do. Or maybe because of the bureaucracy, he or she just gave up. Many of the physicians I interact with describe this appeals process as a bit of buzzword bingo. The savvy ones are pretty good at using the right words that show up on the algorithmic lists to make convincing cases for why their patients should get the services they're requesting. And so one has to wonder whether the process is really curbing inappropriate utilization or simply turning into a game that physicians need to play to get the tests they think their patients need. The peer-reviewed data supporting the RBM system has been pretty limited. But here's some more work by Dr. Dave Levin looking at how utilization of CT pretty much flattened out after a large payer engaged one of the RBMs. What's not shown on his graph, but I illustrate here in red based upon the text in the article, is that they reported that utilization was previously growing at a rate of 10% per year. So a flattening, if really attributed to the RBMs, is not insignificant. And here's some work looking at the early experience with another company, pretty much showing the same thing. But again, the window studied here, like in that prior paper, is pretty narrow. It shows association, but it's difficult to make the case that there was causation. That is, how much of these changes in utilization were attributed to RBMs, or to the many other policy initiatives that you now know were being implemented at about the same time. Nonetheless, the RBMs do like to take credit for saving insurers money, but some provocative work by health economist David Lee and colleagues calls into question whether there really were savings at all. Indeed, insurers save money by contracting with RBMs, but the costs that were transferred to referring physicians navigating the bureaucratic approval process were pretty similar on a dollar-for-dollar basis. Lee's team created a model using some of the estimated savings from the articles I just showed you, and then estimated the cost to physician practices of working their way through the escalating process of denials that we've also talked about, ultimately showing that the savings in those costs pretty much cancel each other out. And so the important questions raised from this work are whether RBMs are really saving society money as they so claim, or just shifting costs to physicians so that insurers can capture bigger profits. Whether that's at play more broadly or not is unknown, but what is known is that physicians pretty much universally hate RBMs. Let's talk about the results of a physician survey commissioned by the American Medical Association several years ago with regard to pre-authorization more broadly. Physicians, not surprisingly, thought that pre-authorization was a hassle, and they asked for automated processes rather than to have to call a 1-800 number and talk with a bureaucrat each time. Additionally, the rules are widely thought of as being too vague and confusing. Perhaps, and maybe I'm just cynical, the companies that are incentivized to deny services may just want it that way. The wait times are too long, say many physicians. Sometimes they have to wait days, not hours, until the RBM returns their telephone calls. And overall, they find working with people at these companies difficult. Again, my personal opinion, maybe a little cynical, is perhaps that's by design. The harder they make it to get a study approved, the less likely perhaps that the physician will order it again, particularly if the company is paid on a contingency basis, as we know that some are. Remember I told you a few minutes ago that the first-line agents for most of these companies were not nurses and not doctors, but rather clerks, and many of them have no medical training. So what value do they add, other than just denying services and making it harder to work one's way up the authorization chain, appealing and then again appealing denials, which just adds to the cost shifting that we've already talked about. One of my personal pet peeves is code-specific pre-authorization, where the RBM approves only a single CPT code and gives the radiology practice no discretion at all to modify that test. Here's a real scenario I wrote about some time ago. A patient with a questionable nodule on a chest x-ray is referred for a CT scan of the chest. A contrast-enhanced examination is pre-authorized by the RBM. But after offering a history of a prior near-fatal contrast reaction, the patient, under the direction of the radiologist, undergoes a non-contrast study. Payment is later denied on the basis of non-approved service with a statement that the pre-authorization was specific for a contrast-enhanced examination. That's what I call deauthorization. We'll talk about that some more in an upcoming module on dealing with the problematic order. The best practice, and I personally believe the ethical practice for these companies, is to approve a family of codes. That's what this one RBM does. If you have an authorization for a contrast-enhanced CT scan, like in that last example, you can perform the examination without contrast without any penalty, meaning you don't have to play the Mother May I game. It's all about doing the right thing for the patient, but unfortunately, not all of these companies work that way. The other problem with some of these organizations is the variability in criteria transparency. NIA, for example, has pretty specific criteria published and accessible on its website. You put in details about the plan and the condition, and it transparently displays their coverage guidelines. That's good. But for some of the other companies, the only way you can find out what is or isn't covered is by submitting a request and hoping for the best when you call their 800 number. And some will even go so far as to give you a pre-authorization number, but then later deny that same test on the basis of medical necessity. That, in my opinion, is nothing more than bait and switch, but it's the system that many of us are stuck working with. The problem, in my opinion, with some of these organizations is that they don't have radiologists in leadership positions, or enough of them involved in decision-making. So, that's why this slide was intentionally left blank, because the RBM process essentially bypasses the value that we as individual radiologists could add, if we were willing to do so, in the utilization management process, and leverage the relationships that hopefully we are all fostering with our own local referring physicians to provide the pre-service work about medical necessity that we talked about during the RBRVS valuation process. Let's pivot then to where the radiologists are and have been for over 25 years. That is, developing our own criteria. And I'm talking about the American College of Radiologists appropriateness criteria here. The appropriateness criteria are evidence-based guidelines that are developed and reviewed annually by expert panels in diagnostic, imaging, and interventional radiology. And importantly, each panel includes leaders in not only radiology, but in a variety of clinical specialties. Now, as this is being recorded in 2018, there are 178 diagnostic imaging and interventional radiology topics in the appropriateness criteria, covering over 912 clinical variants. Like the one on the left, which scores the appropriateness of various imaging examinations in the setting of acute chest pain when aortic dissection is suspected. Or this, on the right, which does the same in a variety of scenarios when appendicitis is suspected. The variants here are for a pregnant woman and for a child, which represent just two of the several variants where one modality may be preferable to another depending upon an individual patient's unique clinical presentation. In recent years, the ACR took the appropriateness criteria one step further, working with industry to embed the criteria into decision support software that makes this information available in real time when physicians are making clinical decisions and using their electronic medical records to order imaging studies. This isn't just an exercise in doing the right thing and helping physicians make good decisions for their patients, although that is extremely important. It's also the way to help ensure that we as radiologists will get paid for our work. You see, because of the Protecting Access to Medicare Act, the PAMA legislation that was passed several years ago, physicians will be required to consult appropriate use criteria, AUCs, prior to ordering advanced diagnostic imaging services for CT, MR, nuclear medicine, and PET studies for their Medicare beneficiaries. So, for our practices to get paid by Medicare for these studies, we'll need to make sure that our referring physicians are using these tools and that we capture the decision support numbers that they generate. That's why many radiologists in leadership positions with their health systems are working with their medical staffs and their IT teams and their EMR vendors to make sure that these software systems are in place in time to meet the law, integrated and working in a way that's as seamless, non-obtrusive, and also educational as possible. One thing to note is that while the American College of Radiology's appropriateness criteria is the basis of the engine for one of the biggest vendors, that system also includes criteria from several other organizations. So this is not just about the ACR. Now, there is an approval process that CMS has created where you, say in your own health system, could create all of your own criteria and then get them on the official AUC list if so approved. But most health systems will, not surprisingly, be relying on criteria that have already been in place for some 25 years, rather than inventing their own wheels. The interfaces will all look different depending upon your EMR and what AUC system you use. Here's a screenshot of a proprietary one described in an article in the JCR some years back. All of these are similar in the following way. Referring physicians pull down a scenario, check some pertinent positives and negatives, and ultimately some sort of score about an imaging study's appropriateness is generated. Here's another one that uses a color-coded system, which is the direction that some of the big software vendors seem to be going. Green means you can move forward. Red means stop and think for a little bit as to whether this is the best test for your patient. Unlike the RBM industry, for which data are pretty thin, a more robust body of literature is showing good results for embedded decision support tools, like this one showing how the rates of imaging in low-yield scenarios dropped over several years after implementation of such a system. Or this one showing how ongoing quarterly growth in advanced imaging, in this case CT, slowed down after decision support rules went into effect. Not surprisingly, the more that physicians use these systems, the more that the rate of low utility examinations declines. That's the goal here, not to cut imaging utilization overall, because we all know how valuable imaging is in many situations, but to reduce its use in those scenarios where it really doesn't help at all. Despite all of the rigor that went into criteria development, these software systems, however, are not perfect. Sure, the ACR's appropriateness criteria has 912 variants, but patient presentations are more complex and varied than that. And so the good systems don't have hard stops, meaning that if a scenario doesn't exactly match up with the criteria, you're not prohibited from ordering the study. That's what some of the RBMs have done, however. Remember? The physician-friendly and patient-friendly systems will give referrers the ability to override a low score and simply explain the rationale. That creates data on the back end to allow those physicians to be educated if they turn out to be repeat offender outliers. And it also helps collect data to identify areas where new rules and variants may be necessary, so that the criteria can continue to be improved over time. It's important to note that several of the studies about ordering decision support tools that I've showed you are over a decade old. But unlike the RBM research, which pretty much just all fizzled out, work in this space continues. Here is the abstract from a recent paper in the JCR, which shows that low utility studies decrease after implementation of a decision support system. That's what we want, of course, but also, and this is important, that the utilization of appropriate studies actually goes up at the same time. So whether it's for attending physicians, trainees, or nurse practitioners and physician assistants, there seems to be not just a reduction in imaging, which is what the RBMs are selling, but rather a shift to more appropriate imaging overall. And that's how radiologists and their practices can indeed add value. Those observations of note held up across various modalities: CT, MR, ultrasound, and PET and nuclear medicine, which is all good to know since federal law, remember the PAMA legislation we just talked about, is going to be requiring the use of this for Medicare beneficiaries. And with these tools soon to be implemented in a pretty ubiquitous manner, it's possible that private payers may accept these as well and cut out the 1-800-MOTHER-MAY-I, RBMs, and fall back on these validated and transparent tools that can be used during real-time clinical decision-making. Which brings us back to the role of radiologists. Remember, we have had very limited roles in the RBM companies. But with tools like this, there are a lot of potential roles for us to become increasingly relevant and add value. As leaders in making our health systems aware of the PAMA mandate, as leaders in bringing clinical teams together with the EMR and AUC software vendors, and as leaders in helping educate our referring physicians about the appropriate use of medical imaging. All these activities are aligned with other things that we've talked about in Replete about how to add value to our referring physicians and to our patients. And also ways to ensure that we get paid appropriately after PAMA kicks in as well as to optimize our own cost scores under MIPS and get paid appropriately under that program as well. In summary then, historic interventions to curb unnecessary medical imaging have proved challenging in many ways. You've heard that efforts to eliminate financially driven self-referral have been largely ineffective, and that RBMs have imposed financial and workflow burdens on physician practices that those physicians pretty universally consider unreasonable. As we seek to add value to our healthcare systems and successfully capture legitimate revenue in our own practices, it appears that real-time decision support tools hold the most promise to optimizing the appropriateness of medical imaging. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the Replete initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in Replete.